So I have the distinct pleasure of introducing our next speaker for this morning, Dr. Thalia Field. She's joining us all the way from British Columbia. So welcome to Ontario. Thalia Field is a stroke neurologist and clinician scientist at University of British Columbia, where she's also Director of Research for the Vancouver Stroke Program and past postgraduate fellowship program director. Her primary interests are related to clinical trials, process improvement in clinical trials, and stroke in young patients. She is currently leading a national study on treatment strategies and prognosis of cerebral venous thrombosis. And today she'll be speaking about antithrombotic therapy in stroke. Thank you so much, Dr. Field.
Thanks so much for the introduction. And yes, as a neurologist interloper, it's very exciting to be here. So thank you very much for the invite. These are my disclosures and disclosure of financial support and strategies for mitigating potential bias. So our objectives today are to review our current best practices in antithrombotics for secondary prevention after non-cardioembolic stroke and to outline some areas of uncertainty. I'll speak a little bit about the paradigm shift, focusing more on early therapy after minor stroke and TIA for early prevention, and speak briefly about the role of some of the newer antithrombotic agents. So unlike other types of atherosclerotic ischemic events like coronary artery disease and peripheral vascular disease, stroke has more heterogeneous mechanisms. So in addition to large artery atherosclerosis, either in the extracranial or intracranial vasculature, there are other mechanisms like cardioembolic stroke or paradoxical embolism, small vessel disease, or things that are slightly more exotic like dissection or hypercoagulable syndromes. So in turn, different mechanisms are associated with different rates of recurrent events. And in turn, we're trying to target our antithrombotic strategies differently, as well as kind of the rest of our secondary prevention strategies as much as possible. These are some rates of recurrence of major adverse cardiovascular events in some of the recent stroke prevention trials. And what you'll see is that regardless of stroke mechanism, overwhelmingly the most common recurrent event, even in intracerebral hemorrhage, are ischemic strokes. So that kind of is the primary area of focus where we're thinking about in terms of antithrombotic strategies. The other thing I just wanted to point out again is that the recurrence rates are different by stroke mechanism. And for example, you'll see that intracranial atherosclerosis, even in the manicured context of the clinical trial, has very high recurrence rates, about 10% per year. So as I was saying, the mechanism may affect to some degree our secondary prevention strategy, and antithrombotics are just part of this complete breakfast with other vascular risk factor reduction. And there are a few stroke mechanisms where we definitely have excellent evidence for very targeted treatments, for example, carotid intervention for symptomatic disease, PFO closure, anticoagulation for major risk cardioembolic sources. And then with respect to risk reduction otherwise, there are some stroke mechanisms where, because of certain trials, there's evidence that's slightly better for one stroke mechanism than another. For example, in trials of intracranial atherosclerosis, exercise ended up being associated with risk reduction, and for the atherosclerotic strokes, intensive lipid management has better evidence, and in turn for small vessel disease, we have better evidence for more aggressive blood pressure targets. But in general, we kind of have a pretty standard approach to risk factor reduction. So I think we had hoped to have kind of a similar one-size-fits-all antithrombotic strategy for different types of stroke mechanisms, but those dreams were a little bit crushed by the ESIS trials. So ESIS is embolic stroke of undetermined source, and it was kind of a broad category that, in part involved occult cardioembolic strokes from atrial fibrillation that hadn't yet been diagnosed, but could also encompass things like atherosclerotic strokes from non-stenotic large artery disease, or PFO at the times before that there were PFO closure trials and favoring evidence for that. So ESUS, we were hoping, was kind of a broad category where you could empirically anticoagulate someone with a DOAC and call it a day. And there were two trials. There was Navigate ESUS, which used rivaroxaban 15 milligrams daily and versus aspirin, and then Respect ESUS was using dabigatran atrial fibrillation dosing versus aspirin. And both of them were equivocal trials. Rivaroxaban had a higher rate of bleeding than aspirin in Navigate ESUS. In Respect ESUS, the rates of bleeding were similar between dabigatran and aspirin, but that's because the bleeding rates were kind of higher overall in Respect ESUS. So basically, the bottom line was that we were kind of unable to empirically anticoagulate everyone with an embolic stroke where we didn't have an obvious major risk cardioembolic source. What's interesting, though, is that there have been several sub-studies, in particular from Navigate ESUS, just looking at kind of fine-tuning those different categories that make up what we refer to as these ESUS strokes. And what's interesting is that, you know, there are some patients that we think the responsible mechanism was probably non-stenotic large artery disease, and there's very little overlap between those patients and patients that have left atrial enlargement. There's still a large proportion of patients where, you know, we have no idea what the mechanism was, about 70%. And then what's interesting in some of these sub-studies, looking at kind of hypothesis generating trends with respect to who may benefit from empiric anticoagulation, it's the sort of people that you might expect would benefit. So patients with left atrial enlargement, patients who had PFO, patients who had, in this recent study, what they call left ventricular dysfunction, which is basically like any sort of reduced ejection fraction or wall motion abnormality. But again, you know, these are hypothesis generating. These percentages here just basically show you what percentage of the total trial population they made up. So again, kind of small numbers, but this has formed the rationale for further trials looking at subgroups of patients that may benefit from empiric anticoagulation. Right now, there's a trial called Arcadia, which is aspirin versus therapeutic apixaban in patients that have markers of, quote, left atrial cardiopathy. So either left atrial enlargement, elevated BNP, or kind of an electrographic adjudication on their ECG. But these are the current Canadian best practice guidelines, currently not recommended to use anticoagulant therapy over aspirin for secondary stroke prevention in ESUS strokes, but additional trials are ongoing. So just to shift a little bit, there has certainly been an increased focus in the last 10 years or so to start antithrombotics as early as possible, and in particular with patients with minor stroke or TIA, where there really is quite a difference in terms of their trajectory if you're able to intervene early. So on the left, you'll see data from a study called CATCH. So this was a study from the University of Calgary where they enrolled 500 consecutive patients that had high-risk TIA or minor stroke. And when I say high-risk TIA, there are symptoms like lateralizing weakness, speech disruption, or prolonged events lasting 10 minutes or more that are associated with both higher likelihood of having MRI markers that this was actually true ischemia, and also a higher risk for progression or recurrence. And what you'll see is that that graph on the left, you'll see that the rate of progression or recurrence is very front-loaded. The curve goes up right away, and sort of the median time to a recurrent event was in the first 24 hours. The different curves, so the red curve is patients that have CT angiogram markers of either an intracranial occlusion, so clot sitting in an intracranial artery, or some amount of large artery stenotic disease. So those patients are certainly at higher risk, but there are other patients, say, with a fluctuating small vessel disease syndrome or other things where you can also have progression within that early window. But certainly we know that early antithrombotic therapy changes changes the trajectory. Another point I just wanted to make, because it does come up in the non-neurology world, is, well, this patient just had a TIA, this patient had a minor stroke. I mean, I would say the distinction with TIA is that the differential diagnosis is still in question. But, if transient ischemia is at high suspicion, I consider them to be a continuum. Whether or not symptoms have totally resolved is often in the eye of the beholder. People with TIA can have dysfunction related to cognitive problems. They can have fatigue. Someone who does one exam may find a little bit of residual weakness that someone else might not find. So really, we treat them the same way. We consider their rates of progression and recurrence equally. Patients that have these, quote, high-risk symptoms, so again, kind of more prolonged events, lateralizing weakness or transient speech issues, about half of them will have MRI evidence of recent ischemia. But what's interesting, and I'll come back to this a little bit later, is that even in patients that don't have these high-risk symptoms, about 13% of them in this recent study that we did actually have MRI evidence of recent ischemia as well. So again, we kind of treat minor stroke and TIA the same way as a neurological emergency. So the evidence for antithrombotics in the very early period in this patient population is derived from a number of trials that have happened over the last couple of years. There was CHANCE, which was in the Chinese population. They had randomized patients to 3 weeks of aspirin and clopidogrel in combination, then aspirin monotherapy versus Plavix monotherapy, and the primary outcome was recurrent stroke at 90 days. The patients that were on dual antiplatelet therapy had a very robust reduction in recurrent stroke, about 30%. The rates of recurrent stroke were fairly high at 90 days, 8% versus nearly 12%. So we were very interested in the results of the POINT trial, which was very similar, but in an international population. So those patients, really the differences were that they were randomized within 12 hours of their event instead of 24 hours, and that they were on dual antiplatelet for 90 days. So there was also a robust risk reduction, 25% risk reduction, but as you can see, the rates of recurrent ischemic stroke were much lower than they were in CHANCE. More recently, there was the Thalia trial, which looked at aspirin and ticagrelor for 30 days versus aspirin alone. We didn't participate in that trial in Canada because most people felt that aspirin Plavix was already standard of care, and we didn't feel comfortable randomizing patients. So the Canadian Stroke Consortium, as a country, decided not to participate in this trial. But certainly there was a benefit for ticagrelor and aspirin over aspirin alone as well. And just like hot off the press, last week is the CHANCE-2 trial, which looked at clopidogrel and aspirin versus ticagrelor and aspirin in patients that had point of care evidence of loss of function for clopidogrel metabolism. So they did point of care testing in a Chinese population, and in patients that had at least one of 3 loss of function alleles, they were randomized into the trial. Patients that were on aspirin and ticagrelor had, again, robust risk reduction by nearly about a quarter in terms of rates of recurrence at 90 days. And you'll also note kind of the rates of recurrence are a bit higher than they were in POINT, but this is kind of the risk that we're seeing in terms of leveling off on dual antiplatelets. So I think, there will be open questions as to whether or not we incorporate loss of function testing into our own clinical practice, or whether or not we should kind of empirically use ticagrelor if it becomes more accessible or less expensive. Another controversy is how long we give the dual antiplatelet for, given that we have POINT and we have CHANCE, which had different durations of dual antiplatelet. So this is a study combining data from both of the trials, and basically they found that the risk-benefit balance in terms of risk of bleeding and stroke prevention balanced out at about 3 weeks. The longer you're on dual antiplatelet, the higher your risk of bleeding. The bleeding is mostly due to GI bleeding. So for this reason, kind of the best practice recommendations in most patients is for 3 weeks of dual antiplatelet and then followed by antiplatelet monotherapy. unless your patient has some other compelling reason to be on dual antiplatelet for longer. And the patients that we make an exception for, like I had said earlier, intracranial atherosclerosis has a very high risk of recurrence. And so we do recommend 3 months of dual antiplatelet in these patients. They quote a trial called SAMPRIS as the evidence to support this, but SAMPRIS was actually a medical versus stenting trial where everybody was on dual antiplatelet for 3 months. So there's not really a comparison. One thing that we are interested in, though, is kind of looking at other antithrombotic strategies to augment in this high-risk population in particular. And that's where something like dual pathway inhibition has become of particular interest. So, the thought is with atherosclerotic plaques, there's thrombosis that's mediated both by platelet aggregation as well as tissue factor exposure. So by using both antiplatelet and anticoagulant effects, there would probably be some synergistic benefit in terms of risk reduction for further arterial ischemia. So based on evidence for using rivaroxaban in the acute MI group, there was a study called COMPASS, which I'm sure you're mostly familiar with, where they were looking at patients that had stable large artery disease, so coronary artery disease or peripheral vascular disease. Within the peripheral vascular disease group, patients could have had either previous carotid intervention or an asymptomatic carotid stenosis, but no recent stroke. People were randomized to one of 3 arms. There was aspirin alone, there was rivaroxaban 5 milligrams twice daily alone, or there was rivaroxaban 2.5 milligrams twice daily plus aspirin. And the most robust risk reduction with respect to the aspirin arm was in the rivaroxaban and aspirin arm. There was about a 25% risk reduction for all comers. And we also got quite excited because in particular, there was a risk reduction for stroke. And so there was an MRI and cognitive substudy, and I'll give you more information about that in just a minute. And what I would say is that in the MRI substudy, it was interesting. Only 4% had a clinical history of stroke, but about a third of them actually had stroke when you looked at their MRI. And so yes, overall, with respect to clinically evident stroke, there was a major risk reduction in patients that were on rivaroxaban and aspirin in comparison to the aspirin alone arm. The hazard ratio was 0.58, so really profound risk reduction. But, what I find really interesting is that those are the clinical strokes, and the patients where there were kind of statistically significant differences were the cardioembolic strokes and the ESA strokes. But in the MRI and the cognitive studies, there were, lots more covert strokes, 4.5 times more covert strokes than clinically evident strokes. And what was interesting is that there was no obvious reduction in covert stroke or in cognitive outcomes or in progression of white matter disease or anything else that we were curious about between arms. So I just find that interesting. I'm not quite sure why that is. It may be that, don't tell anyone from PHRI that I said this, but, maybe it was a fluke for stroke risk reduction. Or, maybe, not all strokes are the same in terms of in terms of risk profile associated with certain symptoms. I always thought that kind of, a stroke was a stroke. It just depended what part of your brain was affected. But we participated in this really interesting study where we purposely enrolled patients that had that had transient ischemic attacks or minor strokes with non-high-risk symptoms. So deliberately recruiting people who had these very brief spells that may have had weakness or speech or dyscognitive spells or sensory spells. And again, 13% of them ended up having MRI evidence of recent stroke. So I thought that was very interesting. And another very interesting thing that we found about the study is that the rate of recurrence was extremely low in this patient population. So, compared to, 6%, 5% that we were seeing kind of in these antiplatelet trials, the risk recurrence of ischemic stroke at 1 year was less than 1%. So, it's interesting. The risk factors for recurrent stroke are what you would expect, kind of motor speech symptoms, ongoing deficits, older patients, male patients. But it is a little bit interesting. So, certainly at this point, I would not recommend treating, covert strokes and clinically evident strokes differently. But, I do think it's an open question for the future. So back to COMPASS, we have kind of carefully worded the best practice guidelines and carefully selected patients who meet criteria for the COMPASS trial, that it is reasonable to consider the rivaroxaban and aspirin combination and should not be used within the first month after a stroke, as was the design for COMPASS. So other agents under investigation that are kind of newer antithrombotics, we're all quite excited about the factor XIa inhibitors as additional adjunct agents to be used with minor stroke and TIA. There's an ongoing trial with a BMS agent right now that's being tested with 3 different doses versus placebo in patients that are already receiving aspirin and clopidogrel after minor stroke. Their primary outcome is both clinically evident and covert stroke. And very soon, there's a Bayer agent that they'll be doing trials. They're doing trials in MI, they're doing trials in atrial fibrillation, and there's also a stroke prevention trial. They're going to start with minor stroke, and if the safety profile is acceptable, they will escalate to more severe strokes, including strokes after thrombectomy. So stay tuned. I should also mention not just new agents, there's also kind of an interest that's been renewed in cilostazol, which is a phosphodiesterase inhibitor-mediated antiplatelet. There have been some trials that are suggestive of benefit and without increased risk of bleeding as another adjunct agent. So I suspect that there will be some sort of stroke prevention trial with that agent in the near future. So just to sum it up, antithrombotics are just one piece of an effective secondary prevention strategy alongside vascular risk factor control. Routine anticoagulation with DOACs is not a benefit in all comers with ESUS, though there may be benefits for certain subgroups in the future. Benefits of antithrombotics for secondary prevention are most robust when started early, and when you do dual antiplatelet therapy is superior to monotherapy, but whether there will be a dedicated role for clopidogrel resistance testing is an open question. And dual pathway inhibition reduces symptomatic stroke in individuals with stable large artery disease, including those with a remote history of stroke. And stay tuned for the results of additional factor XIa inhibition. So thanks very much.
Thanks so much, Dr. Field. Excellent presentation. I'll invite anyone in the audience to approach the microphones if you have questions. Maybe I'll start with a very basic question. As a hematologist, one of the things that I struggle with is defining ESUS clinically. What are some of the pitfalls that you've seen in clinical practice when you've seen people trying to understand or categorize people with this entity?
It's a big area of controversy and heterogeneous practice, certainly. So, for the clinical trials purposes, ESUS was a stroke where there was no major risk large artery stenosis on your CT angiogram. There was no major risk cardioembolic source on your echocardiogram, and on your 24-hour Holter monitor, you didn't have atrial fibrillation. But, within that, there is certainly heterogeneity. And, I do find myself empirically anticoagulating patients while I do cardioembolic workup. If I have a very high suspicion that they have atrial fibrillation, lots of PACs on their Holter, or they have multiple embolic strokes. Whereas some of my other colleagues will just put them on aspirin because, there was no evidence from the ESUS trials. Meanwhile, we are taking a much closer look at the CT angiogram and going like, okay, well, this is kind of an ugly looking plaque, even though it's not quite stenotic. So, maybe we'll call this more in intracranial athero type flavor without, being, officially stenotic. So, I definitely think that there are different types that influence my own practice, but certainly there is no consistent practice right now between people.
Thank you very much. Jim?
Thanks, Dr. Field, for that excellent presentation. And thank you also for your work on CSVT. We look forward to hearing about your research. I have a question about a case I was asked to consult on. I was on call for our local hospital thrombosis service, and it's a patient who had an ischemic stroke, was put on dual antiplatelet therapy, and then they come to me and say, well, we want to put them on the Compass regimen. Can you kind of, approve this? I said, well, do they have symptomatic coronary disease? No. Do they have symptomatic PAD? No. And then they came back to me and says, well, they've got cerebrovascular disease. They're going to probably have, generalized atherosclerosis, and that's the rationale. So how do I respond to that? And how do you kind of reconcile, what you said with, just blatantly, giving a dual antithrombotic kind of therapy in the absence of, the criteria that allowed people to be entered into Compass? Thank you.
So yeah, with the Compass criteria, in BC, you can get coverage if you to the letter met criteria for Compass regimen. But of course, with intracranial atherosclerosis, we were really, really interested in using the drug in this patient population as well. I'll mention that my colleague Sashi Pereira at PHRI, we're doing a trial called CADIS-ICAD, where patients with intracranial atherosclerotic disease doesn't have to be more stenotic than 20 or 30%. Are randomized to, after they've done their 3 months of dual antiplatelet, they're randomized to aspirin versus rivaroxaban and aspirin. So that's one way that we access it. But yeah, otherwise, sometimes I will, go looking for large artery disease in other beds, or, they have increasingly liberal, I think, private coverage for rivaroxaban under some plans. But, in some cases, there are patients we'd like to give it to, and they can't afford it. And right now our hands are tied, but hopefully CADIS-ICAD will change that, at least for intracranial atherosclerosis.
I'm going to take one more question from the online chat. There are many questions. So we know we've got a great topic and a great talk. This is from Dr. Eric Kaplovich. Could you comment on how your management of ESUS changes in pregnant patients?
We fortunately don't see too many. Pregnancy in stroke and pregnancy, fortunately, is fairly rare. Ischemic stroke is about 12 per 100,000. So, certainly we kind of do a stroke in the young workup. We're much more interested in potential sources like paradoxical embolism, potential hypercoagulable state, depending on where they are in pregnancy. It's interesting sometimes to do echocardiograms, both, while they're pregnant and then afterwards, to see if there are any changes, especially if there's a PFO in terms of hemodynamics. Obviously this is not a patient population that we, could anticoagulate with a DOAC, but certainly I would discuss with thrombosis, whether it's worthwhile putting someone on low molecular weight heparin, depending on what we thought the mechanism was. If we thought it was possibly paradoxical venous disease versus an arterial event, in which case aspirin is reasonable.
Thank you very much.